30 seconds for everyone to join who's attending online.
It was if you're just making one cloud like t-shirts.
Okay, well, let's get started. Can everyone hear me? Good afternoon, everyone, and welcome to the University of San Francisco's MSDSS seminar series in data science. My name is Sean Butcher, and I'm the Partnership Director for the Data Institute. I will be the MC for this presentation. This seminar is brought to you by the University of San Francisco's Masters in Data Science program and sponsored by USF's Data Institute. If you're interested in learning more about the Data Institute or helping with the Data Institute missions, you can email us at datainstitute@usfca.edu. Alternatively, you can visit us on the web at usfca.edu/data-institute. I also wanted to remind everyone that Data Institute is offering several certificates this March and April. This includes ethics, introduction to machine learning, SQL for data analysis, and applied machine learning. For more information about the certificates and how to sign up, please visit us on the web at usfca.edu/DICERTS. Today, I am pleased to welcome Julien Penders, who is the co-founder and COO of Bloomlife. His talk today is titled Improving Prenatal Health with Medical Grade Wearables and Large-Scale Data Analysis. Julien is going to be answering questions during the presentation. So if you have a question and you're attending here in person, please put up your hand and I will hand you a microphone. If you're attending online, please enter your question on the Q&A box, which is either the top or the bottom of your Zoom screen. Don't enter your questions in the chat area, please enter them in the Q&A box and we'll get to them. That said, welcome Julien.
Thank you, Sean. Can you hear me?
Yes, I can. We can hear you, yes.
All right. Hi, everyone. It's a bit hard. I can't see anyone, so I hope you've all set up over there. So it's a pleasure to be here today and be able to share some of the work that we have been doing at Bloomlife. Bloomlife is a company I co-founded a bit over 6 years ago now, with the goal to bring new technologies and new innovations to the space of maternal health and prenatal health. And so today I'll share with you kind of the results of our work over the last 6 years, using medical wearables, combining this with large-scale data analysis to make an impact in the life of moms-to-be and their babies. So as Jen mentioned, we try to make this as interactive as possible. Although I do not see you, I encourage you to ask questions and interrupt at any time, especially if something is not clear, something you're just curious about, just jump in and yeah, be happy to kind of discuss and go through those different things during the presentation. So here we go. Hi, everyone. Now I can see. Cool. So look, kind of an opening statement, like 131 million is the number of babies that are born every year globally. So most of those babies, of course, this is an amazing event in life. It is a life-changing event for most parents or parents-to-be. That happened to me 3 times. So every time it is life-changing. Unfortunately, what we don't necessarily know, that we tend to forget, is that for many people, it doesn't go like as happy as you would like to. There is complications during pregnancies, complications during birth, and the goal really of what we're trying to do at Bloomlife is how can we make that experience enjoyable and wonderful for everyone. If you look at the kind of a state of maternal health today, I just kind of give you a bit of a snapshot of where the field is. It is an area of medicine of healthcare where we're spending a lot of money from at a national level. In the US, there is every year $110 billion that are spent on pregnancy only for the US, it's a huge amount. Similarly, in Europe, the numbers are similar, 85 billion euros spent every year on pregnancy. And if you look at the incidence of pregnancy complications, it's 1 in 5 moms will have some type of complications during their pregnancy. So it is pretty common. So 20% of all pregnancies will have some type of complications. And 1 in 10 babies are born preterm. So what does preterm birth means? It's a baby who's born before 37 weeks of gestation. And so 37 weeks of gestation is the threshold when the baby is fully mature and ready to get out in this world. A baby that is born before 37 weeks is a baby which is considered to be preterm. Of course, you have different level of preterm. It can be very preterm or early preterm, which is going to be like 28 weeks, 30 weeks, which has severe impact on health. And then you have the just the preterm, regular preterm is going to be 34, 37 weeks. Preterm birth has a huge impact on the health of a baby. It is actually a lifelong determinant of health. So babies are born preterm, but typically have complications that they will have to live with during their entire life. And I'm thinking of sometimes it's like brain-related, like cerebral palsy. It could be also complications related to the lungs not being developed, so more like a respiratory complications. So it has a lot of impact also on the long term. So it's not just a problem at birth; it really is something that a baby will carry on during his entire life. And if you contrast to that, like this incidence of complications, it's interesting to look at, okay, what's the amount of care available for pregnant women in the US? And it is striking to note that 50% of the US counties are lacking a single OBGYN. So it means that for half of the counties in this country, there is not a single OB, not a single obstetrician available for moms. So as you can imagine, this is a huge access to care issue. It means that moms have to travel long distance to be able to seek care of an OBGYN. And this is something that really puts the healthcare systems in the US here under stress. So this is the state of maternal health today. How is this evolving then? If we look over time, there was a recent survey, or a recent study by the Blue Cross Blue Shield of America, which look at how maternal health and prenatal health in particular has evolved over 4 years between 2014 and 2018. What this survey shows is that the situation isn't great, but it's actually getting worse. If you look over those 4 years, the survey has shown that there was a greater number of women who are entering pregnancy with pre-existing conditions. It means that a mom who's going to get pregnant already has some type of conditions. It could be some level of hypertension. It could be some diabetes, for example, or overweight. So some level of pre-existing conditions that will, of course, impact her pregnancy. Then if you look at the number of women experiencing either pregnancy complications or childbirth complications, we see that those two things are on the rise. And overall, over those 5 years, the combined rate of pregnancy complications and childbirth complications has increased by over 30%, 31.5%. So it's a huge increase in the prevalence of complications, both during pregnancy or during childbirth. What we also see is that women who have pregnancy complications will be twice as likely to have childbirth complications. So there is a direct relationship between a mom having a complicated pregnancy and possible issues during childbirth. And to make things worse is that it doesn't stop really at birth, it just starts there. And we see that with these increasing increasing number of pregnancy complications, we also see that the rate of women showing symptoms of postpartum depression, so which is after birth, also is increasing by nearly 30%. So we have a situation which is not like great, and it's actually getting worse. There is really something we need to do about that. And so if we look at the space of prenatal health and maternal health from a science and technology perspective, it is striking to see that really nothing has changed in about 50 years. Like the technologies that we use today to monitor pregnancies like the one that you see on the background here. It's called a cardiotocogram, which is something that measures the health of moms and baby. This is a technology that was first introduced in 1972. So we're talking, over 50 years ago. And so what's the problem is that, first, it's antiquated, clearly. The problem is that it's impossible to do this type of checks anywhere else than the hospital. It is a machine that costs quite a lot. It's a machine that needs to be operated by trained professionals. So this machine there has to be used at the office at the hospital. It means that there is no way to monitor pregnant women outside of the hospital. Another problem is that there are known risk factors for pregnancy complications, but they're very poorly addressed. They're also very poorly followed on, simply because there isn't a good way for doctors and moms to keep track of the risk factors and therefore being able to act upon that.
Julien, were you supposed to be sharing your screen? Were you sharing some slides this time?
Yeah. It's not showing?
Not sharing. You need to go ahead and share.
Oh, okay. Oh, yeah, because you shared something, so I got kicked off, I think. Okay, well, thanks for bringing this up. I think it's it is indeed important, as you see. Let's see. It's better now. Can you see something?
Yes, you can see it. Thank you.
Can you see it big now? Yep. You see the full screen?
Yes, we can. You
Okay.
mentioned something in your background that we were going to show as a device or something at the first screen. Could you back up to that so everyone can see what
It will come. Oh, here we go. So that's the device I was talking about here. So you can see at the background this device. So you can see the machine at the back here. You can see also those belts. So this is what's used today. So it's pretty bulky. Requires a mom to be hooked up to a hospital bed. Require moms to wear those belts. And as I say, it's really limited to bedside in a hospital or in clinical offices. So that's the state of technology today. Hasn't changed in 50 years. As I indicated, it's also the problem that it's really hard to track risk factors. And the other problem with this technology being linked to the hospital is that there is really no data available between the visits. So there is very little data available to doctors or to moms to predict or monitor, even monitor like pregnancy complications or state of pregnancy. It's really just every 2 weeks or every 4 weeks, the mom will show up at the hospital, should have a check, and that's it. In between those checks, there is not much happening, not much data being collected. So there is clearly a huge lack of data in that space. To illustrate this, I think this example is very striking. So this is what's called a Friedman curve. And so maybe just kind of a bit of background. So the Friedman curve is a curve that shows how cervical dilation, so it's kind of progress of labor. So that's a curve that is used during labor. So when the mom gets at the hospital and she's about to have her baby, we're going to do the medical staff will track how much she progresses in the labor, right? And so this is measured by cervical dilation. So it's just the opening of the cervix. And we look at cervical dilation over time. And there is this curve here that kind of shows what a labor progress should be, right? And this is used as a reference curve everywhere in the US, in Europe as well. So it is a very standard curve that is used for tracking labor progress. It is, again, standard practice, standard of care. So now if you look back, where is this curve coming from? What was this curve based on? So it is something that's there for over 60 years. It's actually based on a study in 1955. It was an observational study that was done at a single clinical site on first-time moms, so first pregnancies, and we tracked cervical dilation over time. And based on this data, the Friedman curve was established. However, if you look at the populations, first is one clinical site, so it's not much heterogeneous there. First-time moms, so nothing tells us that it's applicable for second-time mom and third-time, etc. It's also all Caucasian patients. 55% of the patients had forceps, which means they had to get the baby out to help to basically grab the baby out. And 96% of the users were sedated with drugs. And this is the curve that is used today to track labor progress for every single woman. Although the curve clearly was based on extremely biased and very small data set, right? And that is, again, I say this is the standard of care today. So what's the consequence of this? Well, what we see in the US is that 31% of US birth births are done through C-sections. So that means a third of births are through C-sections, which is much higher than what is typically recommended by the by WHO. So it's a lot of rates of C-section, and of course that increases the risk on the mom and increases the risk of the baby. And if we look at the number one reason to do a C-section, it's something that's called labor dystocia. So labor dystocia is the lack of progress in labor. So it basically, to put things simply and to oversimplify a bit, is just like if a mom doesn't follow that curve after 24 hours, we're going to the clinical team may decide that it is not progressing and will decide to do a C-section or can decide to do a C-section. And so that's really an example where limited data from a very old study, very narrow study, got its way into clinical care and is used today and as a consequence on how we provide and how we deliver care. Right? And so clearly, like this should change. Nowadays, we have new technologies, we have better monitoring tools, we have new techniques such as data science to actually get more information out of data. Clearly, there is innovation that needs to be brought in this space. And it is happening. I think there is a lot of opportunities in our space, in women's health, and the intersection really of women's health and maternal health and data science. There is a lot of opportunities to do things better. There is a lot of opportunities to help moms and doctors get more information about the pregnancy and therefore have a positive impact on maternal and neonatal outcomes. And this slide just kind of, for your information, summarizes some of the companies in that space. And really in the last 5 or 6 years, it's really is a space that has received much more attention from the startups and from the VC community. So that's really exciting, I think, as an entrepreneur in that space, to see the amount of interest that's going to that space. And that makes me very hopeful and positive that we will have and we will see the necessary changes in that space in the near future. So let me talk a little bit about what we do at Bloomlife. At Bloomlife, our goal is to define a new standard of care for prenatal health. And we do that by developing a prenatal care platform that combines connected devices and data analytics to do 3 things, really: increase access to care, empower future moms, and improve outcomes, both for the mom and the baby. So this is the 3 things that we set ourselves to do, using or leveraging, let's say, new technologies and data analytics. We do that for 3 stakeholders, and it's always important to understand which problem we're solving and who we're solving the problem for. The first, really, at the center of it, it's the moms to be, the expecting mom. We want to deliver peace of mind to moms. We want to give them a greater sense of control. And we want to allow her to do clearer communication with our care team, clear communication with also within her family. On the provider side, we want to save time. We want to save time for the doctor and for the healthcare providers. We want to enable earlier diagnosis, and we want to improve the quality of care. And eventually, by doing those 2 things, we also address the needs of payers and insurers, which is less complications, meaning lower costs, and of course, also happier customer, happier insurance members. So we're really trying to address the needs of those 3 actors, those 3 stakeholders in that space, and deliver solutions that will basically help the 3 of them. At the center of our approach is a medical wearable device. It's the device that we have developed over the last decade, really. That is a device. It's a patch-based system, so it sits on the woman's abdomen, and it will track parameters of the mom and baby during pregnancy. Of course, depending on where we are in pregnancy, we will measure different things. So typically, early on in pregnancy, we will track things like activity of the mom, heart rate. We will track her stress level. We can also track her sleep. So that's things that we can do since the very beginning. As soon as she's pregnant, she can start using the system and track those things. As we get into the 2nd trimester is when the mom will typically start feeding her baby. Then we can start tracking movement of the baby, what we call kick counts. And eventually towards the last trimester, so the 3rd trimester, the last 3 months of pregnancy, we'll also have information about the fetal heart rate, so the heart rate of the baby, and contractions, eventually up until a situation that leads into labor and birth of the baby. So in all those parameters, they've been reported. I add a few references, 5 references. All of those parameters have been studied, and it's been shown that they have a direct impact on the health of the moms and the health of the babies. And by better measuring those things, or really just measuring these things at all, because it's not measured today, by measuring those things at all, we can start helping moms and doctors taking better ownership of their health, and also starting providing information that can help to do better diagnosis or early diagnosis of pregnancy complications. Maybe just one slide I wanted to share with you on how do we, it's a tough nut to crack, right? There was a lot of research to be done. There was a lot of new technology to be developed. And so as a startup or a small company, we got to think of how are we going to go about solving that issue and bringing innovations to mom doctors and insurances. And so the approach that we followed at Bloomlife is really organized in 3 steps. We decided to start by addressing the needs of future moms. So we decided to develop an initial product that would address the questions that pregnant moms have, with the goal to provide them with peace of mind during their pregnancy. That's the first step. So it's a consumer product, and I'll speak more to that afterwards. So that was the first step: develop a consumer product that moms love and that answer the questions that they have. Once pregnant moms start using this, we will start collecting data. It's like you could look at it as a gigantic experiment. Every time a mom will use the data, we would ask our customers, are you willing to share that data with us so that we can perform research and use that data to do digital biomarker discovery? And that really leads us to our second step. So we will literally crowdsource a gigantic data set that we can then use to do digital biomarker discovery. To what end? Really, the idea being to see if we can track physiological parameters, health parameters of mom and baby, and track them over time, correlate them with pregnancy outcomes, and see if we can identify early indicators, early markers for pregnancy complications, with the idea eventually to be able to act on those markers to impact or to reduce the risk of certain pregnancy complications. So that's kind of the second step of the strategy. Once we have that, once we've identified this digital biomarker, validating them, got them through the FDA, then comes the third step, which is really to implement them into the healthcare systems, into the current healthcare workflow. And that goes through clinical utilization and payer coverage. That's really, at the end, where we want to be in defining a new standard of care for remote prenatal monitoring. It is a long journey. I would say that today we somewhere like 6 years in, we somewhere around step 2. Trying to get our way to step 3, but it is something that we've kind of taken over the last 5 or 6 years, and I'll share with you in a bit more details how we use wearables and how we use data analytics to get us there.
Julien, we have a question from the audience.
Yep.
Hi, Julien. Can you hear me?
Yes, I can hear you.
So with the data collection with moms, are you seeing that you have an imbalanced data set where only sort of like moms that had successful trials are sharing the data versus, moms who, for example, like had a miscarriage, like aren't so willing to share that data?
It's a great question. So we didn't see that much. Of course, she opts in or opts out at the beginning. Like, so she's going to sign up for Bloomlife. She's going to get her device. And at that time, we ask her if we can use her data. And she has always, of course, the option to opt out later on. We did not see a lot of bias there. And I got to say, the response rate was really good. So we had over like 95% of our users were willing to share the data for scientific purposes. So it was very well received, I think, by our users. So we didn't see a bias on that respect. No. So it could have been, but we didn't see that. Yes, good question.
Julien, we have another question from the audience.
Yep.
Hi, Julien. Thank you for the talk here. My question here is, I guess, for the data collecting from moms. I'm just wondering, as I also do some research in wearable, isn't there any hesitance from the mother, like, because it's not only related to the mother itself, might be related to the fetus too? How's that response from the volunteers or the who you're collecting the data? I can see that it might be it became more beneficial during the COVID era, because the access to the hospital might be like more dangerous. But I see a lot of mothers whenever we bring the wearable research that various concerns related to the frequency of the like data transmission,
Yeah.
whether it would affect anything harmful to the children. Just want to hear about your experience there.
Yeah. Yeah, it's a good question. So there's two aspects to your question, I think. So there is the safety aspect of the device, and it did pop up. I think some of our users were inquiring about this. We did a lot of, there's a lot of testing that can be done. There are standards they need to comply to. So we did all of that to show that the device is totally safe. And it's much to a certain extent, it's a totally passive device. So I didn't get into the details, but it's no ultrasound. It's not an active device, so it doesn't beam any energy into the belly. It just listens. It's kind of a ECG type of technology, if you wish. So it just captures the biopotential of the surface of the body. So it is a completely passive device. So we did have the question from some of our users, and we just explained. And in the end, it's their decision, right? So I think we designed everything so that it's safe, and we showed it is. But in the end, it's a decision, of course, of the customer or the mom in this case to use it or not to use it. And of course, we always respected their decision. There was another aspect to your question, which is about what information they get access to so that they don't get anxious. I think that's a very important question. And I'll talk a little bit more about the consumer device afterwards, but you cannot there is some information you cannot provide to a mom without medical supervision, right? And so you need to really be careful about what information you're going to give a pregnant mom in a consumer setting, right? And there is really only little you can do. It cannot be any medical information. It cannot be anything that could lead to anxiety. It has to be something which is really more educational. Think of something like more like a Fitbit type of thing, where there is no medical actionability to data. Otherwise, you cannot do that directly. So and then that's kind of what we're doing now. We're moving more into the medical space where you can then provide advanced information on the baby, but that is a very different type of offering that you cannot do just as a consumer product. So you always need to be very careful in terms of what information you provide, what you can provide, if you are within a medical product or not. So it's a very very important aspect, absolutely. And I'll come to what the device does. So it will be a bit clearer then. Yeah.
Thank you. I have one more question. It was really interesting to see that you can monitor the mother's heart rate as well as the fetus heart rate as well. Just I want to hear, because based on my experience was that like that happens until I was in a labor. So the idea here is that you're separating the two signals to correctly monitor between the mother's heart rate and also the baby's heart rate at the same time to track the stress level and health. Am I understanding correctly?
Can you repeat the first part of the question? I missed the first 10 seconds of your question.
Oh, so I saw on the slide that on the third trimester, you start tracking also the baby's heart rate as well. So is the device can separate the signal of the mother's heart rate as well as the heart rate to monitor the both sides?
That's correct. Yes, indeed. The device is capable of separating. That's part of what we do, is that we can separate the signals from the mom from the signals from the baby. Yes, absolutely. Yeah.
That's awesome. Thank you.
Yep. So kind of going through each steps of the process. And so I want to speak a little bit about like how to address the consumer need, right? With the goal to crowdsource physiological data at a scale that was never be done before. And so a consumer product was a simple patch. It's a pregnancy tracker. The only thing it does, it's time contraction. So again, to one of the questions that was raised, there was not a lot you can do without being a medical device. And so what we really limited it to something very simple, which is just kind of think of a timer, like a timer that you would use to time your contractions. This just does that for you, nothing more, nothing less. So it's an informational device, again, not providing any medical type of information. The goal here is really to reassure, is to provide peace of mind to mom so that she can understand a bit more what's happening, especially in first pregnancy. It's really hard to know what is a contraction, what's not a contraction. So the device will help her understand what a contraction feels like and help her track her contractions. So it was a device that got us a lot of different product award. Also, the feedback we got was really positive from moms, and I think that's also part of the reason why I think they were willing to share the data with us, is that they had just a very good experience using the product. It really make a difference in their pregnancies, and therefore they're willing to share back, right? They're willing to help the community getting better, help getting more information out of the data and share the data. So I think it's by delivering a product that really addresses a user need, address a consumer need, and really provides a good experience, you will gain a lot of trust from the end users, and we can build this relationship and have them to share data with us. So this was good. We also did a couple of I think one person was asking about possible let's say concern that a mom could have. So we did a couple of small random control trial to show if the technology would create additional anxiety or reduce anxiety during pregnancy. I think this is something you commonly hear when you talk of new technologies and digital technologies. Is more information overload, will that create more anxiety, or will that empower the end user? So we had the same questions, and so we did this trial where it was again a small RCT. So we had two arms in the trial. We had one group of moms who were just undergoing standard of care, and another group of moms who were given Bloomlife, the consumer product, and they were using it during their pregnancy. And then we did 2 checkpoints. So we checked, so we used standard anxiety scales. There was one, which is a pregnancy-related anxiety questionnaire, the PRAC questionnaire, and we also look at empowerment with the pregnancy-related empowerment survey. So these are dedicated questionnaires, so it's very well published. It's used as standard questionnaires in prenatal health. And so we looked at those questionnaires, and we asked mom at 32 weeks, so just before they get the device, the product, and at 36 weeks. And we see if how the level of anxiety and the level of empowerment has changed over those 4 weeks. And we compare the control group, so the one that was just having standard of care, with the group who received and used the consumer device. And so what you can see there was really interesting, I think. So you can see that so if you look at those 2 graphs here, so the first graph is a question in the questionnaire, that is whether she feels anxious about delivery. What you have in dark blue is the Bloomlife group, and in cyan, in light blue, is the control group. So what you could see is that between 32 and 36 weeks, the group who was using Bloomlife became less anxious about delivery than the ones during standard of care. So it shows that through access of this information, so having more information about contractions, help them feeling more in control and help them reduce the anxiety related to delivery. And vice versa, if you look at the anxiety index, the anxiety index is kind of an index that is based on multiple questions in those questionnaires. Same thing, you can see that the group that used Bloomlife had a reduction in anxiety, where the group that was just following standard of care had an increase in anxiety, with a p-value which was here 0.28 on a group of 35. So that was statistically significant. So this was great. I mean, this shows that technology and putting information in the hands of moms is a good thing. And again, I insist it has to be designed well. It should be information that they can understand, information that they can act on, not be something that is of medical value. But there is still a lot of empowerment, a lot of anxiety reduction that can be gone through such a piece of technology.
Hi, Julien. We have another question.
Yep.
Hi. I was just wondering why, if you have any insight on why the Bloomlife group might have much higher anxiety, like than the control group on the top graph.
Yeah, it's a great question. So this is I don't have a good answer for you on this. This is one question, so we have to be a little bit careful. I mean, it's a score between 1 and 5. So the difference here is actually not that big, between 3.6 and 3.9. And the decrease here was also not. It was a trend. It was not statistically significant because it's just one question. So it's hard to say. We couldn't relate that initially. The groups were matched, so it shouldn't have been any difference. So it may just be because it's a single question. The difference is much lower if you look at this anxiety index, which is a combination of multiple questions. So it's a more robust measurement. And so you see less of this here, but the groups were matched. There was no reason why one would be higher than the other. Yeah. Good question.
Thank you.
Yep.
You have another question?
Yep. Do you have another question you said, or?
Hello.
Yeah.
Do you think there is any information about the variance in any of these metrics? Because, I mean, it's probably a stupid question, but it's like if I Google my symptoms or if I Google my condition, it so happens that maybe I get more anxious about what's happening to me, even though it's normal. So is it possible that on average, the pregnant women felt less anxious, but some of them felt even more anxious than before because they were like in the abnormal range or something like that?
Yeah, it's a good question. I mean, it's hard to say for sure. The only thing you can do to address this is make sure your populations are matched, or two groups are matched. So here they were coming from the same clinic, so people with the same background. So there was no reason why one group would be, more inclined to Google or get anxious than the other one. But it could impact, absolutely. I think it's really looking at matching the two groups so that, whatever happens in one group should be matching the other one. But yeah, I think that's, but clearly that could influence that. Yeah. Mm-hmm. There was a question online here. What were the two groups matched on? It's a great question. So we looked at, so again, same clinics, and then we watched them, we matched them for parameters that are gestational age, BMI, and age group also. So we make sure they have a similar age, and also the if it was first, second, or third pregnancy, because that could also have an impact on pregnancy. So that's another thing that was used to match the two groups. Yep, you're welcome. All right, so how did that go? So we launched this consumer project. So we started collecting data. We have to date collected over 12,000 pregnancies, so over 12,000 users. That gives us like over 1 million hours of longitudinal data. So that's by far the largest data set that was ever collected on the prenatal care. Just to give you a reference, the second biggest data set is a data set which is part of the MIT database, and that is a data set that has about 500 pregnancies in there. So it's by order of magnitudes a larger data set. Of course, it is a data set which is collected in uncontrolled environment. It is not a clinical study as we typically are used to it. It's not in the controlled hospital environment. It is used in the home of those moms. They are being active, so not all data is usable. And a lot of the work that we have done is to analyze that data, see which part of the data is clean, see which part is artifacted, and kind of sort that data. But still, given the amount of the data that we have, with good algorithms to prune the data and to extract real information of it, this is a very rich data set to start analyzing it and see if we can find early signs of or early indicators of some type of pregnancy complications. One of the things we looked at is, and maybe to take that as a segue just to illustrate a bit the approach, is labor detection. So one question our team started asking himself is, right, can we use that physiological data to identify early on the onset of labor? In other words, can we define a digital biomarker that will help anticipate that the mom will get into labor? So there is tons of reasons why you would like to do that. There is a practical aspect to it, like if a mom knows that she's going to get into labor, she can get ready for it. But there is also potentially on the longer term a medical implication to it, especially in case of preterm labor. There are interventions that doctor can provide if we detect early enough that the mom starts in labor. It's possible to stop labor. It is possible to accelerate the growth of the baby in case of preterm labor, so that the baby is more ready to get in this world. So there are medical interventions that can be done if it was possible to detect labor early. And so the scientific question that we ask ourselves is, can we use our data set, our crowdsourced data set, to identify a digital biomarker for labor? So maybe kind of just as a quick context is, what is the definition of a digital biomarker? I think there have been a bunch of definitions out there. I like those two definitions, which I think are very similar. There was a definition by Rock Health that says that the digital biomarkers are consumer-generated physiological and behavioral measures collected through connected digital tools that can be used to explain, influence, and or predict health-related outcomes. So it's very similar to what I just described. So you use digital tools, you use wearables, you collect data, physiological, behavioral, and you try to use that to get some indicator of something that can be actionable. Evidation health is using a slightly different definition, but again, goes in very much the same line. Is they define a digital biomarker, or the digital biomarker creation requires direct access to and the ability to integrate longitudinal, medical, behavioral, and contextual data. After that, retrospective analysis works well as a first step in developing and testing hypotheses, but prospective clinical studies are critical to validating the hypothesis and developing robust evidence of the digital biomarker's value. I'll get back to that, but this is super important. Like, we're using the consumer-generated data, as I say, uncontrolled, and it's great because of the volume of data it generates. And that's really unique in that respect, a lot of data. But of course, it's uncontrolled. It's also, the quality is also variable. And so that is a great way to seed and to start the discovery of biomarker. It is not enough to validate the biomarker per se. You need to go back to something which is a bit more controlled, like more classical clinical studies, to validate the digital biomarker in a controlled environment, to make sure that whatever you learned from the crowdsourced data indeed holds ground and holds truth in those more classical clinical trials. So this is important aspect. So this is how we define a digital biomarker and how the process of digital biomarker creation and validation, how it needs to be done. It's a very rigorous process that starts from crowdsourcing the data, but eventually goes back to clinical validation to make sure that what we've discovered through consumer-generated data is indeed true and it is indeed happening. So how did we do this? For us, it really started, so we take the data we collected, and you start really by understanding the physiological changes that are associated with the event that you're trying to predict or to detect. So again, in our case, we're trying to detect the onset of labor. So the first thing we did is that, can we identify physiological changes that are associated with the transition from a state of pregnancy into a state of labor? So we looked at a bunch of different signals. Here I'm just showing two. So one is the top one here is what's called the maternal EHG. So you should look at this. It's kind of it's the EMG of the uterus. So the uterus is a muscle. It generates a bunch of electrical activity, and the EMG, so the electrical activity of this uterine muscle, is called EHG. So that's the first signal you see here. The second row here is just the heart rate of the mom, maternal heart rate. And the third row that we see here is just the motion. Motion of the sensor, so motion at the level of the bed. And so what we did is that we looked at, we pulled the data that was during pregnancy, and we pulled the data that was during labor, and we tried to plot distributions of those measurements to see if we can see a difference, to try to get the feeling for the discriminative power of those physiological signals as it comes to distinguishing between a state of labor and a state of pregnancy. So you can see here those graphs are in red. You have the pregnancy, and in blue, you have the state of labor, right? And so it's really interesting to see that, if you look, for example, here at the EHG, you can just clearly see that the density here, the distributions is very different if you look at the EHG features when you look at pregnancy, compared to labor. Similarly here, if you look at that's another feature here is the mean crossing rate of the EHG against an EMG feature. You could see that you will have more mean crossing rate. So it means more activity really on the EHG when you go to labor in blue than when you have pregnancy. So you have a more active uterus, which intuitively makes sense, but we can see here that the data shows that. Yeah, and here in this case, it's the heart rate on the top one. So what you see here is that as you go more towards labor, you can also see the heart rate of the mom tend to increase, so tend to slip towards the higher value. So
We have a question from the
yep,
audience.
yep. Yeah, go ahead.
Hello. So you are probably getting into this maybe, but I just wanted to ask, what are the data types that you usually work with? Like, are they mostly just frequencies, or are there like just sound waves or any other type of data that you work with?
A great question. Yeah, this is all the time series of electrical and accelerometer signals. So it's going to be, and then we extract features that I skip to that, but we do. So we take it's kind of ECG data and accelerometer data. We do feature extraction, and then we looked at a bunch of features to see which one are the most discriminative. So that's a type of data. No sound wave. We didn't use sound wave. Some other people have. We didn't use sound wave in our work. No.
Thank you.
So once we get this, so kind of this more like it's really observational work, I just say, or description work. So we just look at what features may have discriminative power. Then we started building a model. So the model was a very simple model at the beginning. We just used like a generalized linear regression. And the idea was, can we combine those different features that seem to have predictive power to distinguish between a state of pregnancy and a state of labor? Can we combine them into a score or into a probability of being in labor? And so this graph is a little bit complicated, but what this graph shows, so the x-axis is the time to delivery. So 0 means that the mom is in her last week of pregnancy with reference to when she delivered. So it means that it's delivery up to delivery minus 7 days. 1 here is 1 week before delivery, 2 weeks before delivery, 3 weeks before delivery, and so on. And the probability here, you could see it as a probability of being in labor. So it's kind of a labor score. So the higher the probability, the more likely the mom to be in labor. So that was the very early work where we just simply used a couple of features. And then we tried to build a model that will give us really, again, this probability. So what you see here is that in light gray, these are the cases of moms that were in labor. And in dark gray, these are the cases of moms that were not in labor, so during pregnancy. You can see that you clearly have a difference. Of course, there is quite some overlap. This was early work, but there is a clear still difference in, at least in the average here, between the probability of the moms who are actually in labor and the mom who are not in labor. And so that shows that, you know, slowly we're building this model of being able to detect to predict when a mom is going to get in labor. So this is work that was published in 2018 when we used, in this case, 150 pregnancies to kind of build that model. Then we try to apply that model to different populations. So what you see here is, again, similar model on preterm labor. And so you can see here that you have, again, a pretty clear difference here for moms who were in labor and moms who were not in labor. You can see that you have a clear difference here in the probability. If you mix data of early and preterm, you can see here that, again, you have a pretty clear difference. There is here the average is much higher, but overall you have a pretty good difference, again, between the probability of a mom in labor versus the probability of a mom who's during pregnancy. So that was another paper that we published, again, using the same method on a different data set, which shows that, you know, the model is at least robust to multiple data sets. And so when we got to that stage, we're okay, so we got this crowdsourced data, we started looking and understanding what possible physiological changes could be indicative of labor. We combined those physiological changes into a probability, a score of labor. Now it's time to test this in a clinical study. And so we designed this study to validate basically the biomarker and see, okay, if we take now a controlled study where moms, you know, will be followed, they will be part of a study, they will have medical follow-up, there will be a very clear definition of when she's in labor and when she delivers, and let's see, you know, what the model gives on such a population. So the study is called the WISH study. It was a study that we ran in Europe. It was actually funded by the European Commission over there, and the study is kind of summarized here. So we had we'll be screening including mom in the first between week 20 and 30 of pregnancy, and then the moms will be followed during 10 weeks. So every participant will get a device that you can see here, and she would use it for 10 weeks. So when she started being at week 30 of pregnancy, and she was asked to use it at least 3 times per week, 3 nights per week. And so we're going to start gathering that data, and we got that all the way until until the time that she is in she delivers, basically. So will collect data all the way from pregnancy all the way to delivery. So this is kind of just a quick highlight of the population. So we ended up having 125 women included in the study. You can see age was 30, average BMI 25. We had half of them were nulliparous, and then we have some variability in terms of race. And you can see what's interesting here is that you also look at the risk factors. You can see that 80% of the moms were like low risk and 20% were high risk. And if you remember the statistics that I mentioned before, so we typically expect 1 in 5 moms to have complications. So that's something that you see on the study population. And it is important that when you do a study like this, that the study is kind of representative of the general population, which we had in this case. And so here's the same picture, kind of just flipped from the picture I showed before. So now we're looking at gestational age here, increasing from left to right. And then we're looking at the same probability of labor. And so this is data from the study. And so you can see again here, light gray would be a mom in labor, dark gray is a mom during pregnancy. And again, you can see that you have a statistical significant difference in this value of the probability for moms that are in labor and ones that are the moms during pregnancy. And so you can see here clearly on this graph. We could also do a t-test analysis that showed that that was the t-test on the last week. So those 2 data points here, you could see that the statistical difference was significant, highly significant in this case, which is again very promising. That shows that the digital biomarker that we had developed based on the consumer data holds true when we apply it to a control setting. Then what we did is that we refined the model based on that data. So we split the group in 2 sets, a training data set and a validation data set. We used the training data set to refine the parameters, and then we cross-validated the refined model on the validation data set. So you can see here we kind of split 60-65. Lots of non-labor sessions. It's a highly unbalanced problem, so we have to take care of how to deal with this. And there was quite a few things that go with that, but in the end, this is kind of what we had, and this is the results that we had that we published 2 years ago, I believe. So you can see the ROC, but I think what's really interesting is to look at those 2 numbers. So the sensitivity in detecting labor and specificity, which is 80 and 93%. So is that good or is that bad? It's always hard to say. I think we should put this in context of the accuracy of detecting labor today. And so the way labor is diagnosed today is through a cervical exam at the hospital. And this typically had an accuracy of around 75 to 80%. And so what we see here is that through the use of a digital biomarker using wearable data collected from home, that we can get to an accuracy level which is equivalent to the clinical standard for diagnosing labor. And so that's it's good. I think that's really what we want to be. It shows that you have a tool which is much more convenient, that can be used by the mom herself in the comfort of her home, and that gives an accuracy or performance that is similar to what's used today in clinical practice. So what does it mean practically? Well, this is still early in early work, and so I think we kind of now did the validation, and now we can really get more into the productization of that of those results, which is something we're getting into. But what does it mean practically in terms of clinical care? What, as I indicated earlier, once we have a tool to early identify labor, there are things that we could do. It's mainly 3 types of things. That there is the first here, like we can give prophylactic grafts. So that these are things that will help basically deal and handle the condition of threatened preterm labor, so the risk of preterm labor, that will basically reduce that risk. And so there are medical interventions that can be administered to the mom to reduce her risk of actually delivering preterm. So if we see early on that she has sign of preterm labor, she could go to her doctor, or the doctor could call her and say, hey, this is what we should do. Similarly, if the mom is contracting, And it's possible to reduce the contraction. There are drugs that allow to reduce the contractions. These are tocolytics drugs. And same thing, if we identify early that the mom is contracting and she's getting into labor, it is possible to stop those contractions by giving those drugs. And finally, if again, we detect that early, it is possible to accelerate the growth of the baby, especially in early cases, if the baby is at 32 weeks or 23 weeks, where we would like kind of to accelerate her growth so that, we're ready for the time she gets out. There are drugs that can be done, it's basically corticosteroid, that can help basically accelerate maturation of the lungs. And that will, in the end, reduce the risk of neonatal complications down the road. So it's an example of kind of closing the loop here. It's an example of where you have innovation coming from a crowdsourced data set that in the end can really make an impact in the clinical care. So granted, we're not there yet. I think there is still a lot of work to bring that innovation into the care pathways, but I just wanted here to illustrate, give an example of like it's possible. It is possible through large scale data analytics, through medical wearables, to identify new knowledge, really new markers that can in the end will make an impact on how we provide care. And again, there is more work to be done, but that's kind of where we are on that today. I'm going to switch gear here to looking a bit at fetal well-being. But before I do that, I don't know if there are any specific questions on that last section.
Doesn't look like there's any questions right now.
Okay, cool. So we talked a bit about crowdsourcing data and using that data to power the discovery of biomarkers. I also want to talk a little bit about our work on fetal well-being. Just kind of as a mean of introduction. Again, I'm oversimplifying things here, but if you look at monitoring fetal health, so the health of the baby, today there are three ways this is done. There is a self-assessment. It's kind of always the first layer. There is a self-assessment, which is something that the doctor will typically ask the mom to do, and she will be asked to count kicks, so to count baby movement. So that can be done from home. So that's the good part of it. It's very time-consuming because the mom is asked to basically sit for half hour to an hour and just focus on counting kicks, and she may need to do that every day. So it's very time-consuming on the mom's side. It's notoriously inaccurate just because it is very hard for a mom to necessarily feel all the baby movement. It's also highly variable from one patient to another because some mom may be more sensitive to baby movement, some may be less sensitive. And so it gives a very variable range of output. But this is something that is used today. If there is some concern about the baby or if the mom is high risk, then what's used in sort of care is the cardiotocography. That's the machine I showed you as we were starting this lecture. It's also called CTG. That is standard of care. Every mom who is high risk is going to be put on CTG 2 or 3 times per week. That's just the guidelines. So what do we do? That if a mom is high risk, we're always concerned about either her or the baby. And so what this device does, it's every 2 or 3 times per week, we're going to check on how the baby is doing. So what this device here, it's tracing the baby heart rate with the contraction waves. As I mentioned before, it requires specialized equipment, it requires specialized personnel, and it requires the mom to go to the hospital. So that's standard of care. And then if something would go wrong, if we identify a CTG tracing, which is what's called non-reactive, or that's CTG tracing, which is worrisome for the doctor, then it will go to the third level of fetal health monitoring, which is an ultrasound. So ultrasound is really the full view on fetal health. That's where you're really checking like everything that is happening with the baby. And that again, of course, this is only done at the hospital as well. This is also pretty expensive equipment, and that requires specialized personnel as well. So this is kind of what's done today. And so the first thing we looked at was to see how can we help with the self-assessment. Again, time-consuming, inaccurate. Could wearable devices with data analytics help make that problem easier for mom? And so we started with a pretty bulky setup, I would say, but we said, okay, well, let's try to hook a bunch of sensors on the belly and see what we can measure. So what you see here, it's so we had our sensor, And then there were additional electrodes. So on each measurement point, you see one electrode. That's where we measure the biopotential. So typically maternal ECG, fetal ECG, uterine activity. And then the black thing here is an accelerometer. So on each of those locations, we'll capture the electrical activity and we'll capture the accelerometer. We did a study on 20 women, 60 minutes recording, and we were trying to see, can we detect kicks in a way that could potentially be automated? And so again, that's work that was published back in 2017. So in this case, and I'll skip through the details, but in this case, we looked at a bunch of different models using different type of features, a different set of features, and we were trying to see which model will give us, highest sensitivity and highest positive predictivity value. You can see here the numbers that we have. Again, so each color is a different model, and you can see here the sensitivity results and PPV results. So it wasn't too bad. So we got to sensitivity and PPV level of 75% for the best model, which is much better than what a mom, like it's to give you an idea, there has been studies that looked at the accuracy of self-assessment of fetal movement, and that's typically around 35 to 40%. And so we managed to basically be twice as reliable as what a mom would be in reporting fetal kicks. So that was very positive. And then so if you look here at the curve here, so what we're looking at is just a correlation plot here of the detected kicks. So that's kind of what we measure, and the actual kicks. We were looking at this to make sure that we had no bias, like depending on the number of kicks, fewer kicks or more kicks. But overall, we could see that you have a pretty good correlation between the detected kicks and the actual kicks. The challenge with this one that we found out is that it works well when you have a pretty good coverage of the belly. It gets much harder if you're only looking at one point. So like if you said you would just look at just using the sensor, for example, that has an accelerometer also built in, it became much more difficult to detect kicks with precision. It would work very well if the baby is kind of underneath the sensor. It would be way more complicated if the baby is located at some other places in the belly. And so there was complexity here in translating the scientific results into something that is can be used in the field so in real life with the accuracy that we would need. So it's still work in progress on our side, but just kind of sharing another aspects of how machine learning in this case can be used to try to make a problem, to take a problem away from pregnant moms in simplifying the way they can count kicks and count fetal movements. We also looked a bit at well, actually quite a lot at CTG. So as the way we started, so CTG is a standard of care machine that was introduced 50 years ago. There must be a better way to do that. And so what we looked at is like, can we use our patch or wearable to basically improve the performance, or improve just the comfort and also the performance of fetal health monitoring. So if you look at NST today, we talked about this, limited to clinics and hospitals. It is time consuming for both the patient. She needs to travel to the hospital back and forth. There is 45 minutes at the hospital, so it's easy, half a day it takes her to actually get this test done. And there is a high clinical overhead in having the test, right? So the mom needs a room, so she stays in a room for at least an hour. We need a nurse. So there is a lot of overhead, a lot of cost to actually do that from the hospital. So what we're trying to do is like, there is really like, if we can get a reliable enough technology, there really isn't any reason why this should be done at the hospital. Like this, we live in a world now where everything goes remote. We should be able to do that, remotely. The mom stays at home, she does a test, the data gets transferred to the doctor, and the doctor can look at the data remotely, so that the mom doesn't need to be physically present, and the doctor can still have, the real-timeness of this if it's required. And so that's kind of what we're looking at. The advantage, of course, is the fact that you don't need to be in a hospital. You're improving the patient comfort and experience, and you, of course, allow not to occupy so much of the resources at the hospital. Meaning you don't need a room; she can just do that in her home, so you don't need to occupy a hospital bed or a hospital room. So we looked into this, and so we had that's very recent work actually. We just published the results last February, so last month, at the annual meeting of the Society for Maternal and Fetal Medicine. So what we showed there is that, so these graphs look at fetal heart rate. So we're looking at, can we accurately detect the heart rate of the baby? And what we use as a reference is the CTG, so the device that's used at the hospital today. And so this is work where we do a Blind-Allman comparison. So what you see here is the average reading. So each point is a data point. It's kind of, each point is a heartbeat, if you wish. And this is the average value of the CTG and our device, and here's the difference. And so what you want is that you really want those two lines, all those points basically, to fit into the lines, which are the 95% limit of agreements. We want those points, those two lines, to be as close as possible. And there is standard for that. Like it's for a device to be like the FDA requirements would be for the device to be approved by the FDA, it would need to be plus or minus 10. So what it shows here is that we are well within, the target for the accuracy of the device, which again, it's a good starting point. That means that with a technology which is more comfortable, that can be used from home, it is possible to get to accuracies that are equivalent to what's used in standard of care. So that's one of the more recent work that we're working. And again, this is an example where you're combining wearable data with data analytics to improve, the standard of care as it is done today. Yeah, I think that's great. I will skip those two slides which are more hardware related. Yep, there was a question. Yes, it is. Yeah, there is indeed. It's a very good question. Yes, it is. There is yep, the answer to your question. So the question, I don't know if everybody can see it. What is the mean bias of 0.27 BPM that is reported? So it's a bias error if you compare the two technologies. So it would be the difference between the CTG and our reading. And again, that's a very small fraction that we see here, and that's it is just due to the difference of technology. What our technology is electrical. The ultrasound, the CTG is an ultrasound. So it's why we're using Blind-Allman is that it's hard. You cannot really consider one as a gold standard compared to the other as different technology. What you want to make sure is that they are within limit of agreements that you defined. And so, yeah, I don't know if that answers your question, but the mean bias is due to different in technologies, basically, in devices. Yeah.
We have another question online. Do you believe that the cost of the device will be low enough to allow consumers to perhaps purchase without insurance?
I hope so. That's a great question. I would love to. I mean, I think in the end, yes. I mean, in the end, we're looking at these patch adhesives. They can be in volume. They can be made very cheap. The sensor electronics. Yes, there is a specialized chip in this, but except for that, special microchip that gives us the accuracy we need on the fetal heart rate. But except for that, it is standard electronics. So it's not so dissimilar from a Fitbit or from another type of wearable. And so yes, the idea is definitely when you get to volume, you can really lower the price point. It's not where we're starting. I think we kind of started there with the consumer product. What we did back then, we did talk about the business model, but when we had a consumer product to offset the price, we didn't sell the device, we rented it. So it was a subscription model. And so the users, they were renting and they were paying a weekly fee. And so that is a way for us to make the technology available, which is like in low volume, it is expensive for sure. But even in low volume, to make the technology accessible to as many moms as possible without having to, to carry the cost of, it's like a fancy watch, right? It would cost like $350, $400, maybe $500. Not everybody can afford this. So by making a rental model out of it, it basically allows to lower the price point and make it accessible to more people. So I think that would be one way, on the short term to also like reduce the price point. But in the end, when you get to volume, then you would lower the cost. And yeah, indeed, you won't be pregnant forever. That's absolutely right. We had a lot of returning customers, I gotta say, for second baby and third baby, but I think renting in this case makes a lot of sense. A natural cycle. Yeah, indeed. Great question.
Well, I think we're about out of time. Can we have a round of applause for Julien? So much, Julien, for a great, interesting talk. I want to thank everyone for attending here in person, and I want to thank everyone attending online. And I hope to see you all in some of our future seminars. Thank you so much.
Thank you, everyone. Thank you for your attention. Have a good weekend.